Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Cherokee Health Systems for hosting today's session, Clot-ology 101 with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2016. He is currently a corresponding member of the faculty of Harvard Medical School. Oh, I have the old one, and recently retired from as a senior physician at the Israel Deaconess Medical Center in Boston. And we're very, very lucky to have Dr. Schulman as one of our MAVEN Project volunteers. So Dr. Schulman, when you're ready, please begin.
Okay, thank you very much, Kristen, and good afternoon, everybody. We're going to talk about oral anticoagulants today, and especially their use in atrial fibrillation and DVT and pulmonary emboli. And so we'll have a little some sections on the disease state, in addition to the uses of anticoagulates in those disease states. My disclosure is that I have no conflicts of interest, nor does anybody else who's got anything to do with the development of this session. The MAVEN Project is accredited by the ACCME to provide continuing medical education credits, and they designate this session for 1 hour of Category 1 CME credit. So the learning objectives of this talk are for everybody to understand the pharmacology and the pharmacokinetics of the oral anticoagulants. We're not going to talk about intravenous or intramuscular anticoagulants, heparin or enoxaparin. We're not going to talk about those. To recognize the indications and contraindications of anticoagulants in AFib and DVT-PE, to correctly dose those therapies in AF and DVT-PE patients, and have a sense of how to switch from one to another. In addition, the cancer patients represent a special subgroup of patients, and there are some issues that we will address there. So this is the coagulation cascade. There's an intrinsic pathway and an extrinsic pathway. Both of those activate clotting factors as listed here, which eventually combine to form factor 10A. Factor 10A, under the influence of factor 5A, becomes factor 2A, which under the influence, factor 2A changes fibrinogen to fibrin, and with factor 13A causes a cross-linked clot. Vitamin K antagonists, that is warfarin, inhibit this pathway in a number of places. Antithrombin, of which dabigatran is the example, works in a number of places. And the 10A inhibitors work at this point in the process. So the pharmacokinetics of oral anticoagulants are as follows. Vitamin K antagonist, warfarin, is a competitive antagonist of vitamin K in the liver, so that the more vitamin K you ingest, spinach, other leafy greens, the more warfarin you need in order to remain in the therapeutic range. The half-life is days, and it requires frequent blood tests. There are frequent food and drug interactions, and there are dietary restrictions. On the other hand, the direct oral anticoagulants, the dabigatran, apixaban, rivaroxaban, or edoxaban, are direct, in the case of dabigatran, a direct thrombin inhibitor. In the case of the others, factor 10A inhibitors. There's current research going on factor 11 inhibitors, but those are in clinical trials at the moment. The direct oral anticoagulants have half-lives of 5 to 17 hours. No testing is needed, so that you take the medicine, it works. This was actually an issue in the early days when people were changed from warfarin to the DOACs, because the patients wanted to know how they were doing, what test we could do in order to monitor the therapy. The answer is nothing is needed. And it's also important to know that the half-life is hours, not days. There are no food and drug interactions, and there are no dietary restrictions. So here's a 81-year-old lady who presented to our clinic complaining of a cough. Her daughter requested an antibiotic. Here is her electrocardiogram. She has a rapid, irregular rhythm with no visible P waves and narrow complexes. What is this arrhythmia? Okay, I'm going to put that in the chat. You're right. Okay, good for you. Yes, this is atrial fibrillation. Yeah, you can guess what it is. The medical assistant who did the cardiogram guessed at what she might have when she had a rapid irregular pulse. Atrial fibrillation is the commonest arrhythmia that we see in all of cardiology, in internal medicine, in your clinic, in my clinic, that the electrophysiologists see. It is that common. And this is a brief video on atrial fibrillation, showing the difference between sinus rhythm. So with sinus rhythm, the impulse just starts at the SA node, goes to the AV node, then down his Purkinje system, producing a coordinated contraction and an ECG that shows normal sinus rhythm. On the other hand, atrial fibrillation produces upwards of 350 impulses per minute that originate in the left atrium over here, travel through the atria and bombard the AV node with variable penetrance, which leads to variable recovery times, and therefore an irregular rate. So the characteristic of atrial fibrillation is its irregularity. The pillars for AFib management involve three items, right? Stroke risk assessment and treatment, optimization of all modifiable risk factors, don't forget that in AFib, and symptom management, trying to reduce the AFib burden, either with rhythm control or rate control. The risk factors which can impact the AFib burden are things like heart failure, hypertension, diabetes, obesity, and sleep apnea. So stroke prevention in atrial fibrillation can be either pharmacologic or non-pharmacologic. Pharmacologic anticoagulation would be with either warfarin or the direct oral anticoagulants. Aspirin and or clopidogrel, Plavix, are not effective. So don't use them for this purpose. they were found to be not effective and have the same bleeding risk as warfarin. So it's a ACCHA class 3 recommendation, which is do not do, either because it's not effective or because it's harmful. Non-pharmacologic methods include a left atrial appendectomy at the time of surgery, if you're having cardiac surgery in addition, or the percutaneous insertion of the Watchman device, which is a left atrial appendage closure device. This is just a study of 15,000 patients who, worldwide, who came to emergency rooms with histories of atrial fibrillation. And what you can see is the oral anticoagulation use in non-rheumatic heart disease with a CHAD score of at least 2 is really quite low. Here we are in North America, and so the use is 65% or so. That means that 35% of the people with AFib are not being adequately treated. The message is that oral anticoagulants are underused. So how do you decide to anticoagulate someone? Well, or not, how do you decide whether to prescribe anticoagulants in a patient for whom you believe that it is necessary? Calculate the CHADS-VASc score. Okay, this is a commonly used score of risk factors for thrombosis, for thromboembolism and stroke. Heart failure, hypertension, age, 1 point for age 65 to 74, 2 points for age over 75, diabetes, 2 points for a previous stroke or thromboembolism, 1 point for vascular disease, and 1 point for female sex. And CHADS-VASc scores of 2 or greater are associated with increased risk, and anticoagulation is indicated. There are some additional risk factors that increase the risk of stroke that are not included in the CHADS-VASc score, including a higher AFib burden. So, and long and permanent atrial fibrillation. There are, now that we have monitoring systems that record every heartbeat, we have found that there are people who have very short episodes of AFib, 6 minutes, 12 minutes, an hour, and the longer the duration, more than 24 hours, carries the risk. That's not included in here. Persistent versus paroxysmal is what I've been talking about. Obesity, hypertrophic cardiomyopathy, and amyloid cardiomyopathy, poorly controlled hypertension, low GFR, proteinuria, and enlarged left atrium. Okay, so balance the risk of stroke and the benefit of anticoagulation with the risk of bleeding, right? The opposite of clotting is bleeding. So this is a list of bleeding risks. The two headliners are concomitant antiplatelet therapy and concomitant NSAID therapy. This is the one that's really the biggest bugaboo, because people will take NSAIDs and they won't tell you. So that would be one of the questions you would be asking a person who is anticoagulating. liver or renal dysfunction, alcohol use. Age is an important, at older age, patients are both at risk, increased risk for stroke and increased risk for bleeding, prior intracerebral hemorrhage, prior GI bleeding, and Asian ethnicity. And there are two bleeding scores that people have used to try to assess the bleeding risk. The traditional one is what's called the has-bled score, which was based on patients taking warfarin. Much more recently, late last year, the DOAC score was published with patients on the direct oral anticoagulants. Some of the differences between these scores, I'm not going to go through the whole thing here, but some of the differences between the scores are that there's a better quantification of bleeding risk in the DOAC score. There are stratifications by age, whereas in the Hazlitt score, you get no points for under 65 and 1 point for over 65. And here you get different points. And then renal impairment, short of dialysis, is better defined. And the score includes NSAID use or antiplatelet use. It's not clear that we use these scores very much, but the concept, I think, is useful to be knowledgeable about. So here's a woman who has paroxysmal atrial fibrillation, an 86-year-old woman. She has controlled hypertension, osteoporosis, mild cognitive impairment, but is certainly capable of taking care of her own ADLs, taking her medicines. She lives in an assisted living facility, and she presented with episodes of palpitation and heart fluttering, which turned out to be paroxysmal atrial fibrillation. In the last year, she's fallen twice without any injury. Her eGFR is 56. Her CHA2DS2-VASc score is 4. So 2 for her age, 1 for being a woman, 1 for hypertension. That's 2, 3, 4. Her has-bled score is 1. Her DOAC score is 6. These are both in the moderate range. So the question is, should she be anticoagulated? Give me your answer in the chat. I see some yeses. I see a no. I see yes with great trepidation. I see a maybe. My answer to the question is yes. Elderly patients, as I have already said, are at increased risk of both stroke and bleeding, but the benefit of oral anticoagulation outweighs the risk of bleeding in general. And in terms of fall risk, somebody calculated that it would take 295 falls before the risk of subdural hematoma from a fall would outweigh the benefit of oral anticoagulation. So that the risk of falls is rarely a contraindication to anticoagulation. Rarely. But you need shared decision-making with the patient, making sure they understand the risks and the benefits. And of course, adherence to therapy are crucial. So this is from the recent atrial fibrillation guidelines for antithrombotic therapy in atrial fibrillation. Anticoagulation is recommended if the risk is greater to 2 or greater % per year, which would be a CHA2DS2-VASc score of 2. It's reasonable if your CHA2DS2-VASc score is 1. DOACs are preferred over warfarin, except for mitral stenosis and mechanical heart valves. As I said, aspirin, either alone or with clopidogrel, is harmful. There are some situations where long-term anticoagulation is contraindicated. Severe bleeding from various sources that are not reversible. The guidelines say serious bleeding related to recurrent falls. That would be like intracerebral hemorrhage, not just falls with less bleeding. Anticoagulation is still reasonable when bleeding involving the GI, pulmonary, or GU tract occur, which is treatable. Bleeding related to isolated trauma, bleeding related to procedural complications. So it's still quite reasonable to do under those circumstances. Okay, so back to this. Well, we have this fellow. I guess I didn't show you this. 54-year-old asymptomatic man. This was a routine clinic visit with hypertension. His CHA2DS score is 1 for hypertension. It's under 65, he doesn't have heart failure, etc. Should he be anticoagulated and should he receive aspirin? Put your answers in the chat. Okay, so the answers I'm getting are do not anticoagulate and don't give him aspirin. Here's someone who says do not anticoagulate and maybe aspirin. And here's someone who says no aspirin but shared decision making for any oral anticoagulation. Here's someone who says no. With a CHA2DS score of 1, you certainly could not anticoagulate this person. Aspirin is a no. That's not going to help. On the other hand, some of the experts would anticoagulate this person anyway, but it's shared decision making with a CHA2DS of 1. I think my tendency would be to anticoagulate this person. Okay, so here are some pearls with regards to antithrombotic prophylaxis and atrial fibrillation. Number 1, atrial fibrillation is never a one-time occurrence. It will always return. The stroke risk of intermittent or paroxysmal AF lasting at least 17 to 24 hours is equal to chronic AF. Shorter durations may carry a less of a risk. The pattern, frequency, or amount of AFib does not influence long-term anticoagulation decisions. AFib ablation or the use of antiarrhythmic drugs does not allow the discontinuation of oral anticoagulants. And the risk of clot formation exists with atrial flutter as well. Again, I've already said this twice, aspirin does not count. So here are a number of scenarios with anticoagulation decisions. So starting with an 88-year-old asymptomatic woman, patient shows up in the office, has an irregular pulse, and her ECG shows AF. Should we anticoagulate her? Yes or no? Okay. We have a couple of yeses, and that's the answer, yes. The second patient is a 77-year-old woman with rheumatic heart disease. who has received a tissue mitral valve replacement for severe mitral stenosis, who has permanent atrial fibrillation. Anticoagulate, use a DOAC and warfarin. Yes, with warfarin. Good for you. Yes, that's right. Okay, here's a 50-year-old man who presented with a left hemiparesis. Okay, he was found to have short episodes of AF on an ambulatory monitor. Anticoagulate, yes or no? That one's easy. The answer is yes, because he had a stroke. So that, despite his young age, he should be anticoagulated. This is another patient of mine, a 74-year-old man who had a CABG 3 years prior, after which he was found to have 2 hours of atrial fibrillation about a month later, who has been taking rivaroxaban, but now has persistent hematuria and anemia due to the persistent hematuria. This is the cardiologist's nightmare. Patient who should be anticoagulated and who's bleeding. What happened was he received the Watchman left atrial closure device to try to get him off his rivaroxaban. Incidentally, I saw one in the chat. There was a question about AF following CABG, and is this a one-time event? It's very common immediately following CABG, that is within the first 24 hours. After 48 hours, it's probably not. It's likely to recur. And so we depending on the CHADS VAS score, I would anticoagulate such a person. Here's a 43-year-old woman, status post-provoked pulmonary embolism with a short episode of AF. Should she be anticoagulated? Okay, we have some no's and some yeses. I think I might hold off on this, especially if it was, a very short episode. I would do a monitor, an ambulatory monitor. If no AFib shows up, I might repeat that. But again, this is shared decision making, and she might prefer to be anticoagulated, or she might prefer not to be anticoagulated and take her chances. But the risk of very short episodes, I'm talking about 5-10 minutes of AF, is much less than that of 24 hours or more. Here's our guy again. We've already talked about that, so we can go on. All right. So here's a 48-year-old woman who came to the clinic complaining of a sudden onset of shortness of breath for 3 days. She was seen by one of the nurse practitioners on the 2nd of January. She had no cough, fever, chest pain, wheezing. She's a non-smoker, no leg pain. She works at Home Depot, does a lot of walking. Had a normal exam. Had an ECG and a chest X-ray were also normal. So an albuterol inhaler was prescribed. It did not help. 2 days later, she returned. This is when I saw her. Her shortness of breath was worse. What do you think is going on here? Pulse ox. Yes, Yes, good point. Consider PE. Good point. What happened was her O2 sat at rest was normal, but when we walked her around the clinic, sort of a loop around the clinic, it dropped. Okay. But then she told me, only then she told me that she had a history of a DVT PE 15 years ago when she was on oral anticoagulants. A light bulb went off in my brain, and I ordered a D-dimer, which was 10,000. So then she had a chest CT angio, which showed extensive bilateral pulmonary emboli, and she was treated with apixaban. She's done fine ever since. So the diagnosis of pulmonary embolism requires a high index of suspicion. If you never think of the diagnosis, you'll never make it. The symptoms aren't always very specific. Shortness of breath, chest pain, and not often pleuritic, but that would be a more telling symptom. Cough, the symptoms may be mild or even absent. On exam, a tachycardia, leg swelling or tenderness and tachycardia, tachypnea, and tachycardia would be important findings. Lab tests, the CBC, ABGs, an NT-proBNP and troponin, but the D-dimer is the inflammatory marker of particular interest. On ECG, a tachycardia, but mostly nonspecific STT changes. I think I'll show you that in a little bit. On chest X-ray, some nonspecific abnormalities. It's normal in a minority of patients. I'll show you examples of the Hampton hump and Westermarck sign. And of course, the definitive diagnosis is by chest CT, pulmonary angiogram. So here's a 71-year-old man with hypertension who noticed new shortness of breath and a vague discomfort near his right scapula. He saw his PCP, who ordered an ECG which showed a new right bundle. He was then seen by a cardiologist for an urgent appointment and was scheduled for an outpatient coronary angiogram in 5 days. Here's the ECG. Okay, so there's a sinus tachycardia. There's an incomplete right bundle. There are some T-wave inversions on the right side of the precordium. This is not an anterior MI, especially when you compare it with the previous. Here's the baseline. There's no right bundle. There are no T-wave abnormalities. But what there is the S1 Q3 T3, a clinical finding that was described in 1930 by doctors McGinn and White. If you ever see this ECG finding, you can say, "Oh, that's the pattern of McGinn and White," and you will impress everybody in the room because you'll be the only person that knows that. A chest, a CAT scan showed a large saddle pulmonary embolism, bilateral, increased rate pulmonary pressure and right ventricular strain. ECG abnormalities in pulmonary emboli, the most common abnormality is really sinus tachycardia or nonspecific STT abnormalities. And a quarter of patients have no change. Uncommon, the S1 Q3 T3 pattern in right ventricular strain. So this is the case with a much larger PE, and this is a sign. This is a one of the signs of a poor prognosis. If you have atrial fibrillation with it, or an extreme bradycardia or tachycardia, new right bundle, inferior Q waves, anterior ST segment changes, and T wave inversions. That's all associated with worse prognosis. Here is what's called the Hampton's hump. It's a shadow at the periphery of the lung associated with pulmonary infarction. This is the Westermarck sign, which shows a lack of vessels. Right, so you see the vessels here, but not here. So this is where the PE is, right here. So, establishing a diagnosis of pulmonary emboli, we divide patients into those who are hemodynamically stable and those who are not hemodynamically stable. Patients who are hemodynamically unstable, yes, get a pulmonary angiogram if possible, but you need to treat the patient presumptively. If the patient is hemodynamically stable, then calculate pretest probability, do a D-dimer, get a pulmonary angiogram. If you can't do that, use a VQ scan. Okay, and these are the Wells criteria, which are used in patients with a low, patients who are stable, in order to evaluate for pulmonary emboli. So you get 3 points for DVT, 3 points if any other diagnosis is less likely. It's kind of a tough one. Heart rate over 100, immobilization, previous DVT, PE, hemoptysis, and malignancy, and then if there's more than 4 points, PE is likely. If there's less than 4 points, PE is unlikely. So with DVT, PE, starting and maintaining oral anticoagulation starts this way. For DVT and a low bleeding risk, start with either a DOAC or an enoxaparin. For high bleeding risk, and inferior vena cava filter. That's for DVT. For PE and hemodynamically unstable, you may need to treat the patient presumptively. If they're stable and have low risk, low bleeding risk, either an enoxaparin or a DOAC. And then maintenance therapy, the DOACs are preferred over warfarin. Okay, so what about dosing? Well, with warfarin, I think everybody knows this. Start with something like 2.5 to 5 milligrams a day, and then adjust according to the INR. With the DOACs, the Dabigatran is 150 milligrams BID. Apixaban for AF is 5 milligrams BID. For DVT or PE, the dose is 10 milligrams BID for a week, then 5 milligrams BID. For rivaroxaban, AF, 20 milligrams daily. For VTE, PE, 15 milligrams BID for 3 weeks, then 20 milligrams daily. With edoxaban, 30 milligrams daily. The reason these are different is because this is what was tested in the trials. And so this is what was found to be effective. As far as apixaban is concerned, after 6 months, if you think that the patient should be on lifelong anticoagulation, consider lowering the dose to 2.5 milligrams BID. And how do you switch? Well, going from warfarin to a DOAC, you can start the DOAC when the INR is less than 2. DOAC to DOAC, you just stop it one day and start the next. The target INR for patients on warfarin is generally thought to be 2 to 3 for DVT or PE, for AF, for rheumatic mitral valve disease, for bioprosthetic mitral valve replacement, for mechanical and newer aortic valve replacements, and no other risk factors and other situations for mechanical mitral valve replacement and replacement. The target range is a little higher, 2.5 to 3.5. Or if there's left atrial thrombus, or mechanical heart valves, and additional risk factors, such as some of the older generation surgical aortic valve replacements, like the cage ball and the cage disc values. This is the reason that the INR range is 2 to 3. At an INR of less than 2, the stroke risk goes up. At an INR of greater than 2 or 3.5, the bleeding risk goes up. These are DOAC doses for prophylaxis of venous thromboembolism. It's somewhat complicated. I'll just point out that for apixaban, for DVT prophylaxis following hip replacement surgery, 2.5 milligrams BID, for 35 days, with rivaroxaban, 10 milligrams once a day. Following knee replacement, it's similar. And there are dose adjustments of the DOACs for chronic kidney disease. So let's start with the bigatran. Reduce the dose if the creatinine clearance is 30 ml per minute or lower. That would be CKD stage 4. For edoxaban, lower the dose for CKD 3 or 4. For rivaroxaban, lower the dose for CKD 3 with a creatinine clearance of under 50. As far as apixaban is concerned, the dose is 2.5 milligrams BID. If 2 out of these 3 factors are present, creatinine of greater than 1.5, age over 80, and weight under 130 pounds, reduce the dose to 2.5 BID. But just because a patient is over 80 doesn't mean if their kidney function is good and their weight is normal, where is greater than 132 anyway. The dose would be 2.5, it would be 5 milligrams BID. This is the consensus opinion of the cardiovascular division at Beth Israel Deaconess for stroke prevention in AFib from patients who have CKD or those on renal replacement therapy. And if the GFR, if there's a history of life-threatening bleeding, then refer the patient for a left atrial appendage occlusion device. If there is no history of life-threatening bleeding, and the eGFR is 15 to 49, apixaban would be 5 milligrams BID, but with the caveats that I just showed you a minute ago, rivaroxaban is a reduced dose, and warfarin would be a second line drug in that situation. If the eGFR is under 15, but the patient is not on dialysis, apixaban 2.5 milligrams daily. If the patient is on renal replacement therapy, that is dialysis, you can go back to 5 milligrams BID. Now, a common situation that we run into is a patient who's anticoagulated, who's about to have surgery. What should we do with the anticoagulants? And there are a number of issues. One is the procedural bleeding risk. So here's a partial list of the different operations, and some have a high bleeding risk, some have a low bleeding risk. Dental procedures, especially, are a low bleeding risk. Hernia surgery, GI endoscopy, either with or without biopsy. Those are really the common ones that you're asked about: the dental procedures and the GI endoscopy, or cataract surgery. Then there are other peri-procedural bleeding risk factors. These are the odds ratios for bleeding of, active ulcer disease, a previous bleed within the preceding 3 months, a low platelet count, patient being in the ICU, chronic kidney disease, liver disease, active cancer, etc., including older age. So, decide what the bleeding risk is. And in terms of warfarin, you would omit warfarin 5 days. So the last dose would be on the day of surgery -6. For the DOACs, if there's high bleeding risk, stop the DOAC for 2 days prior to surgery. If there's low bleeding risk, stop the DOAC for 1 day prior to surgery, and then resume when the surgeon feels that the bleeding risk has abated. Okay, so here's a 68-year-old woman with non-valvular AF, hypertension, and heart failure with preserved ejection fraction, who's on apixaban 5 milligrams BID, and she requires a dental extraction. Her Chad's VAS score is 4, 1 for age, 1 for female, 1 for hypertension, and 1 for heart failure. Her eGFR is 35. What's her is her thromboembolic risk high, intermediate, or low? High, high, and intermediate. The answer is high. Okay, what's her bleeding risk? High, intermediate, or low? Low bleeding risk, and dental extraction is low bleeding risk. You're right. So should you interrupt the anticoagulation? Uh, okay. No, no, no. Okay. You're all right. You do not need to with dental extractions. How many days bridging? No, nope. Okay. Okay, there's that. Now, here's a 76-year-old woman with non-valvular AF, hypertension, and a prior stroke 3 months ago, who's on warfarin and requires an elective and requires a hip replacement. Her Chad's VAS score is 6, right? 1 for age, 1 for female, 1 for hypertension, and 2 for stroke. So what's her thromboembolic risk? High, intermediate, or low? High, high, high. You're all right. And what's the bleeding risk? High, intermediate, or low? Yeah, probably high, with a hip replacement. So, which of the following is correct? Omit warfarin for 5 days without bridging. Omit warfarin for 3 days without bridging. Omit warfarin for 5 days with bridging, with enoxaparin. Resume bridging on PO day 1, resume bridging on day PO 5. And Stacy is right. It seems like it's worthwhile waiting at least 6 months after the CBA for an elective procedure. You're absolutely right about that. Um, you know, the answer, I think, would be number 3, omit the warfarin for 5 days and bridge with enoxaparin. And then when would you resume bridging on PO day 1 or PO day 5? The answer to that is when the surgeons feel like the bleeding risk is sufficiently low from the procedure to restart the anticoagulants. So that brings us to bridging. Okay. Avoid bridging in individuals who have low thromboembolic risk, who are on DOACs, who require oral anticoagulation for AF, or for secondary prophylaxis at least 3 months prior to following VT, DVT. Bridging during warfarin discontinuation is really indicated for mechanical heart failure, for an embolic stroke within the preceding 3 months, which is what our last patient had. For venous thromboembolism within the last 3 months, or for previous thromboembolism during an interruption of chronic oral anticoagulation. Okay, and that brings us to cancer patients. Cancer patients are a special subgroup. There are a number of issues to be considered. One is the overall treatment plan and prognosis. What is the therapeutic goal? What is the oncological, treatment? Is the patient on hospice? Is there planned chemotherapy? What is the prognosis? And are there other causes of hypercoagulability, such as a patient who's bedridden? There are a few relative contraindications to anticoagulation in these people, including CNS involvement, thrombocytopenia or bleeding dialysis, or the presence of other risk factors for bleeding, like poor nutrition and hepatic metastases. Apixaban is preferred. Enoxaparin has been traditionally used and can be, although it requires daily injections. Enoxaparin followed by warfarin would be your second line of treatment. And then, what is the duration of therapy in a low bleeding risk patient? For AF, it's really lifelong. Okay. The exception is thyrotoxicosis, because once you treat the thyrotoxicosis, the risk of AF may no longer be present. For DVT-PE, provoked 3 to 6 months, unprovoked lifelong. Cancer patients should be anticoagulated until the patient is in remission, or has a major bleed, or unless there was a major provoking event like surgery. Okay, so now we turn briefly to the management of bleeding due to oral anticoagulants. What do? Stop the anticoagulant, assess for comorbidities, supportive care, control the bleeding, consider transfusion of red blood cells or platelets, and administer a reversal agent, and then reconsider the need for anticoagulation with shared decision-making. I'm going to skip that and just go to the conclusion. Anticoagulants provide us with the opportunity to prevent thromboembolism and its consequences. So evaluate your patient's overall risk of thromboembolism and also the risk of bleeding, and know the therapeutic doses of the anticoagulants and do not undertreat. And with that, I thank you very much. And I think we have a few minutes for questions.
Thanks, Dr. Schulman. We do have a few questions. Just a reminder, you can put your questions in the Q&A box or use the raise hand feature, and I will unmute you. So first question is, when would risk of falls be too great a risk to use anticoagulation? Like any specific scenario?
If there had been major bleeding, like subdural hematoma or other intracerebral bleeding. Otherwise, the risk of falls is, unless your patient has fallen 295 times, which is pretty unlikely, then I would anticoagulate that person.
All right, there's a lot of abbreviations, so I might be wrong in how I'm saying this, but I have never used LMWH intermuscularly. Usually give SQ. Why?
Excuse me. You're right. You're right. It's subQ. It's not intra. It's not IM. No, you're right.
Yeah. Thank you, Dr. Farnan.
Yeah, my error. Sorry.
No problem. Okay. You said AFib always reoccurs. What about in cases of treatable causes like hypothyroidism? Also, does that always recur?
Hyperthyroidism is probably the one situation where if you cure the hyperthyroidism, the AFib won't recur. But other than that, it always recurs. It's not a one-time thing.
No. For patients reporting palpitations, how long should they wear a monitor? Do you prefer Zio patch over the regular Holter?
A Holter monitor is only a day or two. So we're not supposed to talk about brand names.
It's true.
Right? We're not supposed to.
It is part of ACCM. I'm supposed to say, yes, use the generic name, but you can use
Yes. Use a long-term ambulatory monitor. At Beth Israel, we use Zio patches. And so I have tended to use Zio patch as a generic term, much like we use Kleenex, which is a brand, we call tissues Kleenex, right? Even though Kleenex is a brand, and I prefer either a week to 2 weeks over Holter. Holter is only 24 to 48 hours.
Great. With sudden onset of shortness of breath, should we ask about upper back pain and or scapula?
Should we ask about upper back pain? Sure. Sure, that's not a very specific symptom. As is shortness of breath. There are many causes of shortness of breath. And it's probably much more common to have congestive heart failure as a cause of shortness of breath than it is to have pulmonary emboli as a cause of shortness of breath. But if there's no other cause that you can, identify relatively quickly, over the course of a clinic visit, for example, then think pulmonary emboli.
Okay. If someone has post-operative AFib that resolved during admission and is discharged from hospital without anticoagulation, When would you recommend, or would you recommend beginning anticoagulation, even if it's back to NSR?
It depends on the the uh, the surgery. I mean, a pulmonary procedure, pericardial procedure, open heart surgery, uh, at the time, within, let's say, 24 hours of the surgery, AFib can be a one time, can be an isolated event, but people who have high CHA2DS2-VASc scores tend to recur. You cannot assume that that will not occur. And
Um,
so my inclination is to anticoagulate these people.
they followed up with, in this particular patient I had, it was an RLL lobectomy.
Yes, well, sure, sure. I would probably anticoagulate that person.
Okay, there used to be a condition called holiday heart syndrome, which was basically a AFib after binge ETOH consumption. Is
Yes,
is that associated with high risk of recurrent AFib?
yes,
Okay,
yes,
good to know.
yes, yes.
All right. Well, I don't see any more questions. So just a reminder, when your CME survey appears, please click August 8th and Dr. Charles Schulman, and you'll receive your CME certificate right away. And if you think of any questions after this session, remember you can always use the eConsult platform, and you can message Dr. Schulman directly. And we also do EKG, AFib, anything cardiology specific mentoring. So if you're interested, Dr. Schulman could be your mentor. But have a great day, everyone. And Dr. Schulman, thank you so much for another great presentation.
Okay. Thank you, everybody. Take care.